Good morning, everybody. I'm Bruce Waldecker from Oliver Van Dyke Insurance. We're also known as OVD. We're so glad that you've chosen to join us this morning for this very timely legislative update. A big special thanks to Blue Cross and Blue Shield of Michigan for offering the expertise of John Linder and John Schmidt. They're the legislative and policy experts. Now, 3 quick items before we get started. We're going to have a question and answer opportunity, so use the WebEx chat feature to submit your questions during the 45-minute presentation. To find the chat feature, just look for the word bubble down on your screen. Send your questions to all panelists instead of a particular individual, and then John and John will answer the questions after the formal presentation. Number 2, the session is being recorded and will be posted on the ovdinsurance.com website under Summit Events. And then third, we'll wrap up by 10 a.m. After the presentation, there'll be a quick 3-question survey. Would you please let us know what you found helpful, future topics you'd like to see, and suggestions for improvement. So let's get started. John Linder will start us with the national picture, followed by John Schmidt dealing with the state. Let's go, John.
Apologies, it looks like I was double muted. Thank you, Bruce. John and I are happy to be here this morning to provide legislative and regulatory updates. Please, as was mentioned, enter your questions. We want this to be valuable, and we are happy to address questions both regarding what we covered this morning, but also please let us know if there are topics you're interested in that we did not include. We'll try to address those as well. Moving on to the next slide. This is our legal disclaimer page that was written by our attorneys in Detroit many years ago. I'm not an attorney or tax advisor, cannot provide legal or tax advice, but we will have a good dialogue on the political and policy environment. We wanted to start off on our next slide with our take on what to anticipate federally in 2021 with the Biden administration and Democrats having narrow majorities in the House and Senate. First, COVID is the top policy priority for the Biden administration and is expected to maintain considerable focus throughout the year, with a lot of attention on vaccine distribution and the public health and economic response to COVID. Second, during the election campaign, especially during the Democrats' primaries, there was a lot of talk about major health policy changes. But changes of the magnitude of Medicare for All, a public option, or Medicare at age 60 are very unlikely to occur due to the Democrats having just those narrow majorities in Congress. We will, though, see a lot of activity on healthcare regulation in 2021. We expect it to be a very busy year, including efforts to reverse Trump admin policies related to the Affordable Care Act. There were some initial volleys of ACA-related change shortly after inauguration, with a focus on the individual market and Medicaid. On the group side, we are anticipating pretty minimal change to current regulations. There will likely be some changes to reverse flexibilities that have been put in place related to, for example, individual coverage HRAs and association health plans, but the timing of those changes is uncertain. There are some policies that a new administration can put into effect pretty quickly, like the new individual market enrollment period. But anything that is currently in regulation has to go through a formal regulatory process to make changes, and that process can take a year or longer. One significant caveat to that, though, is if there is a legal challenge pending on a rule, a new administration can simply stop defending the rule and therefore expedite changes to it. That is likely what will happen with the association health plan regulation. Though there will be plenty of changes, some significant regulations, like for price transparency, are very likely here to stay. We will see considerable new regulation derived from the Consolidated Appropriations Act, which became law at the end of 2020 and includes a lot of new requirements for groups, which we will get into on a separate slide. During the presentation today, John and I will also discuss the state and federal policy environment related to pharmacy cost, surprise billing, and telehealth, and we'll touch on the latest ACA constitutionality challenge. One of President Biden's first actions was proposing to Congress the outline of a new COVID relief package. That legislation was fully approved in Congress yesterday when the House passed the Senate's version of the legislation. The American Rescue Plan Act is expected to become law tomorrow when President Biden signs it. Democrats had set a target to complete this legislation by this weekend to avoid expiration of enhanced unemployment benefits. The legislation includes key health policy items, including a 100% COBRA subsidy through September, an expansion of individual market tax credits, 100% federal match for Medicaid vaccine coverage, and incentives for states that have not yet expanded Medicaid to do so. The legislation also includes an extension of the enhanced unemployment benefits through Labor Day, additional stimulus checks for individuals, expansion of child tax credits, and funding for vaccines, testing, state and local government, small businesses, among many other provisions. A health policy change we thought might be included in this legislation that did not occur is an expansion of telehealth coverage beyond the public health emergency. It is possible that we will see separate legislation move in Congress later this month or in April that will address telehealth. Moving on to the next slide. In 2020, there were 5 major COVID relief bills, the last of which passed on December 27th as part of the Consolidated Appropriations Act. The CAA also included the fiscal year 2021 federal budget and a lot of policy changes in a 5,600-page law. This slide shows some of the key categories of funding for COVID relief that were included in the CAA, such as additional funding for the Paycheck Protection Program, which I'll discuss more on a later slide, and funds for vaccine distribution and testing. On the next slide, the CAA also includes a number of new requirements for both insured and self-funded group health plans. As written in the law, most of these requirements apply to plan years beginning on or after January 1st, 2022. So this is going to be a really big focus area for us from an implementation standpoint in 2021, and also for regulatory advocacy related to how all these provisions are put in place by the government. This legislation includes a prohibition on surprise billing, which we'll cover on the next slide. Some of the provisions of the CAA are aimed at providing more transparency for consumers, such as the requirement to include out-of-pocket maximum and deductible amounts on physical and electronic ID cards. The CAA also includes price transparency requirements similar to current regulation, but on an accelerated timeline. There is also a continuity of care requirement to maintain coverage for what the law calls continuing care patients when a modification of a contractual relationship results in loss of covered benefits through a provider or facility. Continuing care patient will have to be defined further in patients undergoing institutional or inpatient care. Oh, sorry, go back to the last slide. Patients undergoing institutional or inpatient care, those who are scheduled for non-elective surgery and for pregnancy. The CAA also includes a compensation disclosure requirement where covered service providers will be required to report compensation for covered services provided under contract to a group health plan. While most of the requirements in the CAA take effect in January, the law also requires group health plans and issuers to conduct comparative analyses of the non-quantitative treatment limitations used to test for mental health parity compliance, if requested as of February 10th, so a month ago. We already have processes in place related to mental health parity, and we're updating those related to this law, but we're also awaiting additional guidance from the federal government. Though that requirement went into effect a month ago, the law is only 2.5 months old, and we have yet to see regulations. The CAA also includes a pharmacy and healthcare cost reporting requirement with a first report due at the end of this year, along with provider directory requirements, a prohibition on gag clauses related to provider cost and quality, and grants to states for all payer claims databases. There is a lot here with very significant implementation work to be done. It is going to keep us very busy throughout 2021. As I mentioned, and it will be a very key focus area for us from a regulatory perspective, looking at how this legislation is implemented. Moving on to the next slide. In addition to the federal law that prohibits balance billing and surprise billing situations, we also have a state surprise billing law in Michigan that was passed last year. The way the federal law is structured, if there is a state law in effect that accomplishes the same purpose, then the state law applies to insured coverage, while the federal law would be in effect for self-funded plans. If there is not a state law in effect, then the federal law would apply across the board. So how this all plays out will vary state by state. Both the CAA and our Michigan state law protect beneficiaries from balanced billing in emergency situations and for certain non-emergency situations as well. For example, when a patient goes to an in-network hospital, but one of the care providers, like an anesthesiologist, is out of network. Key differences between the laws are laid out on this slide. The federal law applies to facility, professional, and air ambulance. In Michigan, we previously had addressed air ambulance for ambulance services within the state of Michigan, but we needed the federal government to act in order for air ambulance protections to apply to out-of-state customers. That was a key advocacy priority for us with the federal legislation, and we were happy that that was included. One of the key considerations with this legislation was how would out-of-network providers be paid? Both the federal and Michigan legislation generally use the issuer's in-network rate as the starting point, but the federal legislation does include an arbitration process, which we are concerned could increase cost. In the state legislation, the arbitration process is more limited. Moving on to the next slide. The CAA made available $325 billion for small businesses, including $284 billion for additional loans under the Paycheck Protection Program. And then this week's legislation adds another $7 billion to the program. There were also some policy changes to the Paycheck Protection Program in both the Consolidated Appropriations Act and the Rescue Plan Act to expand access to loans and to change the tax deductibility of loans that were previously received and forgiven. As noted here, the program currently is set to expire on March 31st, but there's a chance that Congress will act to extend it further. On the next slide, price transparency, as I mentioned, is a regulation that was a key focus area for the Trump administration. We expect that this will remain in effect with minimal, if any, changes. Back in the fall of 2019, there was a final rule for hospital price transparency, which requires hospitals to publicly disclose their negotiated reimbursement from private payers beginning January 1st of this year. Some hospital groups challenged this regulation in court, but lost, and the requirements did go into effect in January. The payer price transparency rule was finalized in November and requires that issuers and group health plans disclose all reimbursement information related to basically all billing codes for all provider types. The final rule requires that the member-facing cost-sharing tool be phased in between 2023 and 2024. The other development, as I mentioned earlier, is that the CAA requires a cost-sharing comparison tool as of 2022. The language in the CAA, though, is vague as to exactly what needs to be implemented in 2022, so we are hoping that our existing transparency tools will suffice for next year and that the current implementation timelines for the final rule be maintained. Moving on to prescription drug cost, this will be a big priority for the Biden administration and Congress, but we do not expect a significant change to address RX costs will happen in federal legislation or rulemaking. It's a very difficult area for policymakers to make change. There will be a discussion of allowing the government to negotiate drug prices, but there is little to no possibility of that happening due to opposition from Republicans and from moderate Democrats. I do think we will eventually see legislation passed that will include a Part D out-of-pocket maximum, and we could see a prohibition on pay for delay make it into legislation as well later this year. On our next slide, moving on to the ACA constitutionality challenge. By way of quick background, the individual mandate was upheld as constitutional as a tax years ago. So after the tax penalty was zeroed out by Congress in 2019, a group of Republican state attorneys general filed suit, claiming that now, because there was no penalty, there was no longer a tax, and therefore the individual mandate should be considered unconstitutional and the entirety of the ACA should fall as a result. This litigation is before the Supreme Court, which had oral arguments in early November. There are three questions the justices will have to answer. One, do the litigants have standing to sue? Second, is the individual mandate unconstitutional? And third, if the mandate is unconstitutional, do other parts of the ACA need to fall with the mandate, or can the rest of the ACA be considered severable from the mandate? It is a good idea to typically be cautious about drawing too much of a conclusion from the oral arguments, but I'll venture out on that one a little. It seems pretty up in the air as to whether the justices will determine that the litigants have standing. And if they do grant standing, it also seems pretty 50-50 as to whether the mandate will fall this time. But what was clear from the justices' comments is that there are at least 5, the 3 liberals plus Roberts and Kavanaugh, who seem to have little patience for the argument that any of the ACA should be considered inseparable from the mandate. So right now, it seems like far and away the most likely outcome is that this case will have no impact on the ACA, either because the entirety of the law stands or because everything but the mandate stands. And since the mandate has been zeroed out since 2019, removing the mandate has no practical effect. That being said, since changes to the ACA through the court case would have a very significant impact, we have done considerable scenario planning from both a political and implementation standpoint as to what would happen if elements of the ACA were to fall. With that, I'll turn it over to John Schmidt for our state topics.
Thank you, John. I just want to begin with a reminder, if you have any questions, please feel free to put those into the chat section. We do love questions, and we'll answer those when the presentation is over. On the state side, 2021 marks the beginning of a new 2-year legislative session. In the beginning of this session, the legislature again is starting to look at pharmaceutical costs and how do you bring those under control. It's a big issue amongst constituents and amongst healthcare members. They want to know, how do we make drugs more affordable? How can we afford the prescription drugs that we're being prescribed? So as part of that, recently the Michigan House of Representatives introduced a large bill package that would address, among other issues, pharmaceutical costs. Outlined here on the slide are a number of the provisions within that bill, within those package of bills, and they're grouped in different areas between what would impact plans, pharmacy benefit managers, and then the drug companies. Before I get into the issues that would apply to plans, one thing to always keep in mind when you're dealing with state legislation is that state law traditionally will only be able to regulate underwritten plans. The ERISA self-funded plans are controlled and governed by federal law. You saw that earlier in the discussion regarding surprise billing, and that will often also occur at the state level with other insurance regulations. So there are always exceptions with state law, but always keep in mind that the general rule is a state law regulating insurance will be regulating underwritten plans. So looking what we have here on the side, for the items that would be addressing the insurance side of it, there are bills introduced to prohibit non-formulary switching, placing limits on insurers on when they can switch a drug on the formulary, providing a few exceptions to those limitations. For instances, if the FDA were to declare a drug unsafe, then you could switch your formulary without having to go through the processes within the bill. And also if a generic should happen to become available. There are other exceptions that were provided in the bill, but the general rule is there's more restraints now put on the ability to switch the formulary through the health plan. Another bill was introduced that would prohibit the use or limit the use of a coupon for a prescription drug when a generic drug is available. The theory or premise behind this legislation is that you don't want to be continually encouraging the use of a name brand if there is a cheaper and effective alternative available, again, to help make drugs more affordable for the member. There was also legislation regarding cost sharing caps for insulin. Currently, as the bill is written, they would limit cost sharing to $50 for the insulin coverage for each fill of insulin. So that will continue on through the legislative process. That one actually has made it out of committee right now. There's also a bill that would require a portion of a out-of-network prescription that's filled to apply to your total out-of-pocket maximum. And how this would work is if a member should decide to go to an out-of-network pharmacy to get a drug filled, a prescription filled, and that prescription is less costly than the average rate of an in-network pharmacy drug, that difference in price between what the in-network price is and what the out-of-network price is, the savings there, would then be applied to the out-of-pocket maximum on the member's plan. And then finally on here, there's also was introduced legislation that would require parity for oral chemotherapy treatments. What the bill would require is that the cost sharing and other requirements for oral chemotherapy would be the same as intravenous chemotherapy. This legislation has been introduced into the legislature a number of times over the past years. It has not successfully ever gotten through the process. They have reintroduced it this year again. It is part of this overall bill package that they're considering. And one thing to note is Michigan is one of only 7 states that does not have the mandate. And you can see on the slide the other states that also don't have the oral chemotherapy parity mandate. Moving on now to pharmacy benefit managers. The legislature in this package of bills introduced 3 bills that apply to pharmacy benefit managers. And one of the first things they wanted to do is bring pharmacy benefit managers in line with other healthcare entities that have to do filings with the state, such as insurers. Insurers are required to file their rates with the Department of Insurance and Financial Services, and we're also required to make a number of other filings with the state regarding corporate structure and governance of our entities and so on. So they wanted to bring in parity with the other healthcare entities, and so they introduced legislation that would require these pharmacy benefit managers to do a similar licensure and regulation filing. They also introduced legislation that would prohibit gag clauses between PBMs and pharmacies. And what this means is that there could not be put into a contract a prohibition for a pharmacist to talk to a member that is there getting a prescription filled about potential alternative medications that could be used for that drug, so that they're not prohibited from mentioning other things that may not be currently available to that individual within their formulary line. So they're prohibiting those type of agreements with these gag clauses. And then there's also finally a requirement that the PBMs also make annual reports regarding costs, fees, and rebates. These are for a number of different items that are related to PBMs, and they could include things like the wholesale acquisition cost that the PBM has, the various rebates that they receive from manufacturers, and all the fees that they receive. These would all be reported in the aggregate, but would still be filed in an effort for more transparency. And along that same line, then going into the final column with the issues related to drug companies, they also introduced legislation that would require more transparency for pharmaceuticals and what goes into that cost and how those costs are determined by the company, and along with how often they can do an increase. And so as you can see on the slide, there would be the report to the state on the cost elements of the drug that went into the price increase, and that increase could be no more than 15% a year or 40% over a 3-year period. It also requires the state to notify, or requires the drug company to notify the state of a price of a new drug if the wholesale acquisition cost exceeds the threshold set for a specialty drug under the Medicare Part D program. And there's also was legislation that would limit the ability or the amount or the ability of drug manufacturers to market to prescribers. They put caps on the type of marketing that they can do prescribers in the form of gifts. So these bills are all currently been introduced in the legislature. They're in the House right now. They're going through the committee process. Some of them have made it to the floor, and they're going to be continuing the work on these bills throughout the month of March. Going on to the next slide that we have here, the House didn't limit their look at these healthcare issues just to pharmaceutical costs, and they began touching on other issues too related to healthcare. And one of the first ones was efforts to how do they expand the use of telehealth. As we all know, during the pandemic, telehealth became a very popular form of delivery of care for members. So the legislature decided that they wanted to continue to build on that. And one of the bills that they introduced would allow a health professional that's licensed in another state to provide services to a member that's located in Michigan without that provider having to be licensed in the state of Michigan. Currently, under Michigan law, you have to be licensed in the state where the member is located to provide them the services. This is not unique to Michigan. This is actually very common. A number of other states have this law. During the pandemic, there was an executive order that waived this requirement and allowed members to receive services from a physician through telehealth that wasn't licensed in the state of Michigan, but was licensed in another state. So the legislature wanted to continue this authority that was previously waived under an executive order, and they introduced this. So how this would work, or to put it into, I guess, a real life example is, if say you happen to be traveling out of Michigan and you were going to Florida, and you wanted to continue to see your Michigan provider, you could still have the telehealth service provided to you by your Michigan provider if Florida had a similar waiver that didn't require them to be licensed in your state. Under this law, that Michigan physician could provide you those telehealth services. Or in the reverse, if there was a doctor in another state that you wanted to see that wasn't licensed in Michigan, they could provide you the telehealth services here in Michigan. So this bill is still going through the legislative process. They haven't had a committee hearing yet on this one. There's still some details that they have to work out with the legislation and around how this would work in regards to the other states. The other item here along telemedicine also has to do with a contact lens examination. So after initial exam and evaluation, which must be done in person, this law would allow future exams to be done via telehealth or use various telehealth technologies for contact lenses to get your prescription renewed. 37 other states allow some form of telehealth for vision services. And so Michigan would be joining these other states. Again, this is another opportunity for the legislature where they're trying to expand these telehealth services that have been very popular amongst members during the pandemic. Moving into the middle column, there was a bill that was introduced that would expand the scope of practice for nurse anesthetists to allow them to provide anesthesia services to patients without the direct supervision of a physician. Currently, they're required to be directly supervised by a physician to provide a number of services. So under this, their scope of practice would be expanded and they'd be allowed to provide more services without having to be supervised. This would give them an opportunity to expand access to members to receive certain anesthesia services. And then finally, the last item that they had here was they introduced legislation that would require hospitals to post their charge masters. What the bill actually does is codify into state law the federal requirement for hospital price transparency that went into effect on January 1, 2021. Part of the reason or rationale as to why would they codify into state law something that's already required in federal law is it would give the state regulatory authority then over the same provisions in federal law. Whereas if it was just a requirement in federal law, the federal government would be the sole regulator of whether or not a hospital is properly complying with that law. So again, these bills are still in the legislative process. They're in the committee hearings, and like the pharmacy ones that I mentioned in the previous slide, they also would like to get these done or have hearings throughout March and hopefully get these done and out through the House. One thing to note about this, as I've been talking about, these are House bills. After they pass the House, they would have to go to the Senate, where they would also go through the committee process in the Senate floor before they would go back to or final concurrence or approval by the House. So there's a long process left with these bills. There's an expectation that there will be changes done along the way. So there'll be a lot of updates that go along with these bills as they go through. So, but what I'm sharing with you today is where they stand right now in the legislative process. And finally, on the last slide here, wanted to mention one other bill that's out there. While it's not part of the House package, wanted to raise awareness on it and bring it to your attention because it's, again, a sign of the legislature's desire to continue to address pharmacy issues and making sure that patients get the medications that they need. And under this bill, what it would allow for is an emergency 30-day emergency supply of insulin. So if a member's insulin supply is running low or it should happen to run out, they would be able to go get their prescription filled on an emergency basis in order to ensure that they keep getting their insulin, which is critical for those that need it. Within the bill, there were patient protections put in place to protect the patient and also to help prevent waste. Things such as making sure the pharmacist does try to contact the patient's physician prior to dispensing the insulin, making sure that there's documentation regarding this refill, making sure that there's information about the patient's overall diabetes management, and finally, to make sure that the emergency insulin that's being dispensed is covered by the patient's health plan to ensure that they're not all of a sudden getting a surprise bill or being required to pay for a form of insulin dispensed to them that wasn't covered by their health plan. There are a limit on the number of emergency refills in this bill that they can get in 1 year, and that was placed at 3 by the legislature. And this particular provision, since it's a state law requirement, would only be applying to the fully insured plans because the state in this case can only regulate the fully insured plans. The ERISA plans would be regulated by the federal government, so this bill would not apply to those. So those are the items that I had from the state level, and I think now we have a good amount of time here, I think, left for questions, and we're definitely open. We'd like to hear the questions that many of you may have been asking during this time in the chat feature.
John, that's fantastic. I learned quite a bit, and we have several questions that have come in Before we get to those, just wanted to remind everybody that this session is recorded, and if you want to go back or share it with anybody, you'll find that at the ovdinsurance.com website under Summit Events. And then next, a quick reminder that there'll be a short survey as you exit this session. Please answer the 3 questions to help us improve. So with our first question, this would be for John Schmidt. What are the recent COVID trends you're seeing in Michigan?
Great question. And I think the key word in there is trends. Throughout the COVID pandemic, a lot of what we see is all based on trends and where we're going in the state. And there's been some pretty good ones recently. First off, we do have now available in the state all 3 of the vaccines, the one from Pfizer, Moderna, and Johnson & Johnson, are in distribution in the state. And right now, based on the most recent data, there is approximately 26% or more of the 65 and older are now fully vaccinated, and 55% of that population is now received their first dose. And that's a very positive trend, because the more people that get vaccinated, the more we're going to start seeing the numbers continue to head down, which has been the other thing that we've been seeing over the last couple of months since the peak in November, is that the numbers have been starting to trend down. Now, from time to time, I think everyone needs to be prepared that there will be days where they may spike, or they may go down, or there may be a couple of days where they'll go up. Nothing has ever a complete straight trend down or straight climb up. So, but we've been seeing a lot of positive trends in that area. And as a result of that, last week they did start expanding, opening up more businesses. Most notably, the restaurants went from 25% capacity to 50%. You started seeing the exercise facilities also went from 25 to 30. So the state is slowly starting to open back up again. That executive order is in effect until April 19th. And so hopefully everything keeps heading in the right direction. And just one other note on the vaccinations, overall population, I know I mentioned the 65 and older, total of that 16 and above age group, the state's right now at just over 20% of people are vaccinated. And just this past Monday, the next eligible group became available with the 50 and older that with the pre-existing conditions or caretakers. And then on the 22nd, those age 50 and older, regardless of pre-existing condition, will be able to get the vaccine. So things are improving, and I think it's always a wait and see and continue to watch case counts in that as we go forward.
Thanks, John. That's very encouraging. And we're still accepting questions, so use that chat feature and send us your questions. Our next question, I think this one's for John Linder. Could you please expand on what pay for delay is?
Oh, sure. So pay for delay is a tactic that drug manufacturers use sometimes, where they literally pay a competitor to delay entry into the market. And so it happens sometimes when a generic is going to come to market. And part of this gets into the problems with things like patent thickets, where there'll be lots of litigation and other tactics that are used to keep a competitor out of the market. And it's a big problem and driver for pharmacy cost is limits on competition, and the fact that when a new drug comes to market, it can be not just years, but decades until you have real competition for that drug. And what we see is when you do have competition, when you have multiple generics enter in, the price goes down, not surprisingly. But pay for delay is one of those methods that are used to prevent competition in the market and delay it from occurring. And there is bipartisan interest in prohibiting that practice. And so it does seem like there's a decent possibility that would be included in legislation later this year, but it's certainly something that drug makers will push back against.
Great, thanks, John. And I think this one is also for you. What are the expected changes to how the association health plans are handled? I know you touched on it, but could you go into that a little more deeply?
Yeah, just kind of going back a little bit, folks may remember there was a regulation that the Trump administration put in place about 3 years ago that relaxed regulations related to association health plans. So it relaxed 2 things in particular, one being the commonality of interest standard. So it used to be that if a collection of employers wanted to come together and have one group health plan, you had to have commonality of interest, like the same industry grouping. But after this rule was put into effect, basically like every employer in a state could conceivably come together to be considered one group health plan. The other big thing was allowing what they called working owners or sole proprietors to join into a single group health plan. Traditionally, for a very long time, the DOL had ruled that in order to be part of a group health plan, you had to have your own employees enrolled in the plan. So a sole proprietor without common law employees couldn't be part of a group health plan. Those are the two main changes they tried to put in place 3 years ago. But 2 years ago this month, in March of 2019, a federal court threw that regulation out. And we've been waiting basically ever since for an appeals court decision. It's been at the appeals court level for about 18 months. And then one of the early actions of the Biden administration was that they went to that appeals court and asked for the case to be basically frozen while they considered what steps they wanted to take related to it. The court granted that request, and so there is a reporting due to the court beginning of April. I think what we expect is that at that point in time, the DOJ will file with the court to say that they no longer want to defend the case, and at that point, the regulation will basically be remanded back to the federal government, and we would expect that the regulation will be unwound, which means you would go back to the old rules, the old commonality of interest standard, the tighter regulations around when a collection of smaller employers can come together to create a group health plan.
Great, thanks, John. And then, in the past, there'd been quite a bunch of buzz for Medicare for All. What are you hearing on that right now in Washington? And are there particular folks in Congress that are still pushing for that, or what's the latest trend on that?
Sure. There are plenty of Democrats who would like to see Medicare for All happen. I think basically as soon as Joe Biden won the Democrats' primary, that calmed down because it wasn't something that he had expressed support for. He did express support for things like a public option or lowering Medicare eligibility age. But I think what we're really seeing in practice is more of the emphasis on expanding upon the Affordable Care Act. And that's what we saw in this legislation that passed through Congress the last couple of weeks, and that'll be signed tomorrow, is a pretty significant expansion of the ACA individual market tax credits. And we've already seen regulatory actions related to expanding upon the Affordable Care Act as well. I think we'll continue to see that. There is going to continue to be a group of Democrats in Congress that is very strongly supportive of Medicare for All, but the chances of that happening are basically zero. That they would have to have overwhelming Democratic majorities in Congress to move something like that forward. And I can't imagine getting to that level of majority in Congress anytime in the next several election cycles. So I think it's something that, at least in the short to medium term, is not something that I think is remotely likely to go through Congress.
Oh, John, that's very helpful. That's it for questions. I would like to offer the opportunity for John and John to have any things that you wish I would have asked or some closing statements. How about John Linder first?
Bruce, I do see something in the chat related to telehealth changes, a question about expanding on the telehealth changes that I think probably related to what I mentioned briefly with the federal legislation. And I guess that gets at something that we're watching from a what happens next related to COVID policy standpoint. Last spring, after the emergencies first went into effect, there were hundreds of regulatory changes, mostly aimed at providing flexibilities for providers and how they provide care. And a lot of that was related to removing restrictions on Medicare. And while those limitations are Medicare specific, they tend to have an impact on how all of us access care. I think telehealth is a prime example of that, where before COVID, it was very low utilization on telehealth, and then kind of overnight, it became the primary way that we all access care. And it's kind of funny to think back to, but before all these changes, back in February of 2020, it was illegal, contrary to federal law, for Medicare to pay a provider for providing telehealth on a smartphone in your home. They had to change the law in order to allow CMS to do that. And so there's still things like that, like the site at which you can receive telehealth, the method from which you can receive telehealth, that there's still changes that are needed in law for those flexibilities to continue beyond the public health emergency, so that you don't have to go to a healthcare provider in order to patch into another healthcare provider to get that service through Medicare. And then another one related to telehealth that we're watching for is audio only telehealth, which is an interesting dynamic where CMS is pretty opposed to that sticking around. They have concerns about about fraud risk, which is a very real risk related to telehealth, but there's also a very positive discussion related to what telehealth has done to expand access to care. And something we've seen, particularly with audio only telehealth, is that a lot of the behavioral health telehealth services that have occurred during this time have come through audio only, and it seems like there may be a positive effect related to stigma and reducing stigma related to accessing behavioral health services when accessed through audio only. And so that's a key one. The telehealth proponents are really pushing for CMS and Congress to be more comfortable with audio only telehealth for certain services. And I think it's up in the air as to what will happen with that. I do think it's very likely that eventually they'll change the law so that beyond the emergency, we can keep using smartphones from our home for telehealth. But the audio only one is one that is more up in the air.
Thank you, and thank you for finding that question on telehealth. I want to apologize to whoever asked that question that I missed that, so I'm glad that you picked that up. John Schmidt, any closing thoughts?
Just to build on what John Linder was saying there with telehealth, I think that is one of the big emerging issues in healthcare is how do we handle a new technology? And it came on so fast. I mean, it was out there, but then all of a sudden everyone started using it all at once and really adapted to it. And now it's always a question of how do we get the regulations and laws to catch up to how that works. And there's a lot of how do you patient protection things, licensure things, all those that are related around telehealth that I think over the next year or so, legislatures and governments are going to be looking at their regulations and laws to figure out what do we have to change first, and then how do we do it to make sure that the patient's protected, but they can still get the services that they need and want through telehealth. So I think that's going to be one of the big emerging issue areas that we've seen. There's always one that's out there. Pharmacy will always continue to be an issue as it's related to cost. And so I think that's something just to keep an eye on. And I think going back to the first question that we have, it's always how do we emerge out of COVID? How do we finally get out of this pandemic? And then what's next after it? And how do we just continue to protect consumers and make sure healthcare is affordable? I think is always going to be the issue that's front and center for a lot of legislators, whether it's here in Michigan or in other states.
All right, John, thank you very much. This was so very helpful. A couple things to remind you. This session was recorded. It'll be posted here as soon as it's available, ovdinsurance.com, and then look for the Summit Events spot. And I want to say a big thank you to Blue Cross Blue Shield for loaning John and John to us today. And then finally, if you have any questions that come up later, feel free to reach out to your OBD broker, the person that you're dealing with. We'd be happy to get back to you. So thank you very much to everybody that attended, and to John and John especially. Thank you very much.
Thank you all.
Thank you.